Okay, I wonder if we can get the slideshow set up here while I tell you a little bit about what we're going to do this morning. First of all, good morning. It's really good to see you all, and always a pleasure to welcome folks to this particular convention. I think I've said every time I come a countdown of the years since I first came here. My very first presentation as a graduate student was here at this convention 30 years ago, so it's been a little while. I'm pleased to be back as past president. I have a year left before my full 6-year cycle comes to a close. So it's been really a pleasure to be among you over these years again. I really appreciated the reference to Daniel Heath Justice's work. I understand, Mr. Cole, that you helped to raise that, and others have used it as a platform to ask those really important, provocative, thoughtful questions. We were pleased to have Professor Heath Justice as a visiting faculty member at Harvard this past year, and he's a delight to have around and a great thinker, and he'll be tickled when he hears that Indian psychology was talking about his work, because he works in literary circles and probably is not used to it traveling so far and wide. Today we're going to start with a symposium. The symposium is entitled Insights from 3 Recent Research Reviews in Indigenous Mental Health. And I'm very delighted to introduce 3 early career scholars, 2 psychologists, 1 psychology doctoral student, who will each present in turn with a review that they have conducted, and along with other partners. So you'll see the full authorship teams when they go through their presentations. But what I want to point out for you is that these reviews are really important for trying to get a handle on what we've learned through research, empirical studies, the kind of articles that we're hearing getting published by up and coming people in really important ways. As you all know from our training, no one study answers any important question. We need lots of studies, different angles, different ways of measuring things, synthesizing findings. And so there have been a lot of advances in the past decade or two in terms of how to conduct knowledge synthesis, which is a fancy way of saying how to undertake reviews in a really structured, systematic way so that we can pose a question, search the literature in a reproducible way, and try to see what that literature says in response to a question at hand. And so for each of the different presentations you'll hear today, a particular question was asked. A certain set of databases of psychological studies have been searched, and folks have had a chance to amass and extract information from those studies and to, in a really structured way, try to answer questions posed for each of these. So that's what we're going to hear. I will sit here just to remind you that you asked for a 3-minute warning. I will stand up at 3 minutes so that you don't miss me. And I will wander this way up the steps, and I'll be like a vulture when your time has come and you need to quickly wind down. But first, we're going to hear today from Maria Crouch. Dr. Maria Christina Crouch, Daguetan and Kawennison Nations, is a clinical community psychologist and a postdoctoral research fellow at Yale School of Medicine in the Department of Psychiatry. Her program of research is focused on the intersection of trauma-informed care, evidence-based practices, and practice-based evidence, indigenous approaches, to address alcohol and drug misuse, trauma, and social determinants of health among American Indian and Alaska Native communities from a cultural, strengths-based approach. Now, we have a table up here, but I think we want to see slides. So we should sit here until it's time to come up for a question and exchange, just because we won't be able to see the slides very well if we sit at this table. So without further ado, please join me in welcoming Dr. Crouch.
Oh, perfect. So basically, you're too cute. Everyone will look at you and not the slides. Okay, well, Daguetan, thank you so much. I'm really honored to be here and to talk about what I did across these 3 very important reviews that were done. Like Dr. Gon said, I'm Daguetan and Kawennison. I'm originally from Alaska, and so my family is from a small village in the interior named Anvik, which is in Alaska on the river. We are river people. So hopefully I can get this to advance. So this is about American Indian and Alaska Native participants in the National Drug Abuse Treatment, so NIDA Clinical Trials Network. So it's the NIDA CTN. Next slide. Okay, so these are disclosures I have to put these up because this was done within the NIDA CTN. But what's really important here is that we had approval. We went through the review process of the CTN Publication Committee, and they provided multiple levels of approval and review. Next slide. And so why the systematic review? From the table, you can see that they're doing a lot of the same things. There's this ability to summarize the research, to use data analytic procedures. They're both evidence-based methodologies. They identify gaps that are happening in the literature, but also the scoping review is really a precursor to a systematic review in many ways. It gives an overview of the literature and the topic. A systematic review is to answer a very specific question. And ours, the one that we did, was a systematic scoping review. So in that way, it comprehensive of both. And so what's really important here is it allows you as an individual to read the research, to see what is out there and to understand it. And we often say nothing about us without us. We really want to know what's going on. And so this came out of conversations within the CTN of, we want to know what's going on for Native folks as Native folks. It's critically important. And we also understand that as we step into these roles, these places and spaces, the very nature of us being there is indigenizing and decolonizing. So next slide, thank you. So this comes straight from the Clinical Trials Network. They provide an enterprise in which NIDA, treatment researchers, and community-based service providers work towards new treatment options in community-level clinical practice. And if you want to go ahead and advance. This will be a little awkward because they advance kind of one at a time, but if you just want to, go to the next. So the Clinical Trials Network was established in 2000. It's been around for 24 years now. And if you could go ahead and click through this slide. So there's been some previous estimates of like how much research has really comprised or been composed of Native participants. Only 2%. That actually is very little, but it's a lot if you consider like addiction research as a whole. Next slide. Oh, okay. And so right now there's been hundreds of studies that have gone on. Currently, there are 49 active studies, and 4 of those are specific to Native participants, and the majority are being led by Native people, Drs. Kamala Venner, Dr. Donald Warren at this time. So next slide. So this is the CTN, right? It's a collection of people across the country. These are called nodes. These are where people meet and they talk about the clinical research. I'm part of the Northeast node, but most importantly, I'm part of the Minority Interest Special Group and the Alaska Native and American Indian Special Interest Group. And it was these 2 groups that I'm a part of that we started to have this conversation and came together. Next slide. Because 2 reviews have been done within the CTN. The first was, what has been learned about Hispanic participants that have been engaged in they're not all clinical trials, by the way, in the research within the CTN. And that yielded 24 studies, which is a relatively small number if you think about how many years it's been in practice, the fact that there are very large funds coming from NIDA that are poured into it. And they looked at these particular study themes. What are the characteristics of the studies? Are people being engaged in these studies? Are assessments being done? What does the sample look like? Are there treatment outcomes? What have we learned from the treatments? And then they looked at specifically HIV and risky sexual behaviors amongst the population. We're going to do a thumbs up now, so I'm not saying next slide. Okay, thank you. So this is the next one that was done. This is among the Black participant population. It yielded more, so it was 50 studies, but mind you, this is hundreds of studies that have been done across the years. And they looked at the same things, and they found a lot of the same things, but were able to contextualize those to the population. What's different here is they found that there was a lot of comorbidity. So there was substance use disorder and diabetes. There was substance use disorder and like complex health issues or like lots of substances going on for this population. And they also looked at measurement issues. And this was brought up yesterday during the keynote. Are, the measurements being used appropriate for the population? Are they being normed on the population? Were they developed for the population? Next slide. Oh, sorry, my thumb's up. So really the conversations came out of, and you all as a group know this, that there are so many issues in terms of our treatment. Are we utilizing it? Are we being retained? Are we staying in the treatment? And what's really happening? Is it helpful? Are they culturally sensitive, adapted, derived treatments? And we are also very conscious of the compounding burdens that affect our community: historical trauma, discrimination, systemic structural racism. I already said that, and I just want to reiterate that again, is that there's a lot of money being poured into this, and it's important that that money be poured into us as well as a people. And so it came out of that. So our aim, you can advance just so they can see them all. So our conversation was centered around, what do we not know, but what do we as Native people want to know? How are they looking at tribal identity? Are they gathering tribal approvals? What's the role of racism and discrimination? Do they care about it? Are they looking at it? And are they disseminating? It's so important. We know this, that the information needs to go back to the community, needs to be fed back in, it needs to go out, it needs to get in the hand of not just providers, but peer support, everyone that's involved, the participants themselves. There we go. All right. Nice. So we were really broad. It was any Native participants. If they had any, we included it, but it had to be something substantive. So they couldn't just say, yeah, we looked at Native participants, or just have a weird, wonky little other category, right? And it was any paper or product. So we looked at, but that became not relevant. There was no unpublished papers we could get our hands on, the gray literature, these types of things, or dissertations. And then we excluded, if there was no data, they may have said they had Native people, but if they didn't report anything, that's nothing we can utilize. If they were not CTN studies, and that was really easy to determine, because if they were published prior to 2000, right, the inception of the CTN. We use the Joanna Briggs framework. It's an evidence-based framework. It's readily available online. It's also a framework for systematic reviews in addition to other reviews. We also use Prisma. We searched within, kind of a no-brainer, the CTN dissemination library, but we also looked more broadly across databases. And we went through a very rigorous process. As Dr. Gon was saying, it's very evidence-based, it's very involved. We actually used Kawennison, which is a librarian facing, and we had a clinical librarian who was part of it. And so she got all of the articles for us. She had 2 additional librarians that validated that search, and even at the end redid the search to see if we missed anything. We had at least 2 reviewers look through everything, all of the abstracts. Then we determined that down to like our full articles, read each of those, decided what to include from there. And so these are our search terms. Number 2 is what's important here. We really tried to think of like what a lot of different tribal names that we could utilize that weren't just the broadly, in case there was a study, for example, specifically among Yupik people. And so this is the flow, right? This is Prisma. This is what we utilize. And so you can see it went from 360 to 270 to 188 down to 13 studies. But there were 6 conceptual articles. So these weren't studies. These were more like opinion pieces, commentary. And we felt that they were very substantive. So we included those and summarized them as well. I think oftentimes those types of things are left out, and that's one way that we're left out, right? And so what's really unique about the 13 studies is that 8 of them were 100% Native populations. They were focused on recruiting these participants. All of them got tribal approvals. All of them included both reservation, urban, village-based individuals. And our primary overarching theme, which you see right there, is tribal identity, which included race, it included culture, and it included experiences of discrimination. In addition, we looked at study engagement, which included access and retention. So are they actually able to get to the treatment physically and otherwise? And are they staying in the treatment? We also looked at comorbid conditions because a lot of the studies reported that. And then HIV, risky sexual behaviors, and then this important one that we mentioned, dissemination. How is it going back out there? And that's another one with those 8 Indigenous specific studies, they all disseminated as well. We looked at the other, because those other studies told us, right? And as addiction researchers, we were like, what about harm reduction? What about measurement equivalence, like I mentioned? What about pharmacotherapy, right? Having therapy and medication. And what about substance use outcomes? But none of the studies included any of that, unfortunately. Representation ranged from 1.4%, like I said, to 100%. And so here are the substances: tobacco, methamphetamines, opioids, alcohol, and other drugs. And 7, and these are primarily the Indigenous ones, really said any substance can be included, which is important. Alcohol was identified across those 8 studies as the substance of most concern. They talked about it within, well, I'm going to take a little bit more time. They talked about it within the studies. And then here's the 6 conceptual ones. So we looked at those in terms of synthesizing those. They really gave information about detailed collaborations among the tribal communities, research that was done within tribal substance use centers, and they were exemplars of community engaged research. So imagine if we left those out. I mean, that was a way in the paper that we wrote to really frame what was going on and what is incredibly important to doing addiction research across our communities. So this gives you an idea. Now, if you look, I'm sure you can imagine which ones are the Indigenous ones. They all start with tribal identity. They include dissemination. They include study engagement. And then we have these ones where there's like 1%, right? 1.4%. HIV, comorbid conditions, comorbid conditions, comorbid conditions. That tells you something. They're saying, well, there's something wrong, there's something wrong, there's something wrong. And we included Native people, and here's a little table on them. The other ones were really like, no, tribal identity is important. Discrimination is important. What's going on? What's happening in this community? And how's it affecting treatment? So I highlighted that they were really looking at these really critical pieces of who we are, but importantly of what is happening to us. And the 8 studies across the 13 were really robust. The methods they used were on a continuum from culturally engaged to culturally based participatory to tribally based participatory research strategies. They really thought about the assessment itself. They thought about our cultural identity and our experiences of racism and discrimination and how those intersect within our health settings and across our treatment and getting treatment to folks and how folks utilize that treatment. And then, of course, all of them had dissemination plans of getting that information back, which was really critical, not just for our people, but for the research being done across the board. This should be done for everybody across treatment. Everybody has culture. Everybody has context. It should be considered. Now, we are limited within the CTN, and there were those themes that we didn't find, and that is very concerning in and of itself. And so we were able to propose, here are the ways in which, as Native people, that we want to see it move forward and what's important. We want to see strategies to increase participation. We want more studies with us involved. We want more studies about us with us. We are asking people within the CTN, if there's Native folks, report subgroup data, give us a table, tell us what you know. Don't put us into the other category, and you can do statistical analyses, you can do effect size. There's other things you can look at to actually have something to report, address the issues of cultural identity and experiences of racism. The onus should not be on us because of addiction, it should be on structures, it should be on systems, it should be on covert and overt acts of racism. Okay, well, I'm almost done, but thank you. We also want these areas that we didn't assess, harm reduction, right? There's this emphasis in Native communities that it's like all or nothing. And that's based on a discriminatory view that Native people can't drink. If you're gonna drink, you know, that's the myth of biological vulnerability. Harm reduction says, no, you can drink, we just want you to drink safely, right? Or it's okay that you're using, we want you to be safe. We want you to be able to reduce that use or reduce any harm within your life. We need studies like that. We need studies that look at equivalency of measures. What are the measures being used? How do they apply to us? What measures do we need that we can develop? And then treatments and outcomes. There were treatments, but there were no outcomes. So we don't really know how they're working, how effective they are. And then of course, that's how do we adapt them? How do we roll them out? How do we get them to other settings and other tribal communities? So that's really imperative information that we need. And overall, our main recommendation was that there's an adoption of this concerted effort across the clinical trials network for research to understand barriers to treatment, access, engagement, utilization, retention, and outcomes to address both the treatment, but the research disparities that are occurring across these layers of influence that I'm talking about. And this is the team. So we developed a friendship across this. Dr. Kamala Venner on the far left is Alaska Native woman. You have Dennis Wendt, you have Kathy Berlew. Kathy Berlew is the leader of the minority interest group. Paulette Bacall, she's the leader of the American Indian and Alaska Native Interest Group in the CTN, and also an Indigenous woman from Minnesota. Melissa is our clinical librarian, and then we have Tanya Sorrell and Angela Haney. They both are involved in the minority interest group as well. And so I started this project when I was on doctoral internship, and I did not realize the fact of what these folks did. They were meeting with me like 1 to 2 times a month. In the hierarchy of academia, like I'm nobody, but they really valued this idea. It shows their commitment to it. They were meeting each week. We were talking about these things. We were having consensus. We were downloading all of, essentially you get Excel spreadsheets, looking at those, trying to understand those, because we took this very seriously. And actually during this time, I had a death in my family. They all came together. They sent me a beautiful plant that is thriving. I still have to this day. And so what I just want to say about that is that research can create relationships as well among people that are long-standing, long-lasting, and you can sort of find your people within these places and spaces to continue this kind of work that is so important for us as Indigenous people. So Dogadin, thank you. I also want to say a special Dogadin to the participants themselves. They gave of their time, they gave of their culture, they gave of their emotional labor to participate in this research, and so that we could do this review. And then of course the interest groups that came together as part of this.
Well, thank you, Dr. Crouch. And it is a bit of an irony that the NIDA Clinical Trials Network, which is designed, of course, to conduct clinical trials to find cause and effect relationships, hasn't really been able at this point to do that kind of research for American Indian, Alaska Native kinds of substance use challenges. So hopefully further research to come. Next, we're going to hear from Dr. Anna Kawennison Fetter, who is an enrolled member of the St. Regis Mohawk tribe and a counseling psychologist by training. She's a postdoctoral fellow in the Carolina Postdoctoral Program for Faculty Diversity at the University of North Carolina at Chapel Hill. In her clinical work, she specializes in providing culturally responsive psychotherapy to emerging adults who experience marginalization. Dr. Fetter's research program aims to advance mental health equity by doing community accountable work that draws from critical, liberation, and Indigenous psychology and both quantitative and qualitative methodologies. Dr. Fetter.
Well, I'm really pleased to speak to you all this morning. I feel like Dr. Crouch's review really speaks with or talks with some of the things that you'll hear about from this. So I think that might be fun to make some of those connections and see how that might inform research for the future based on that conversation. So this is the diagnosable mental disorders among natives in the US, a scoping review. You can see all the wonderful folks who are involved in this project that's now in press at Clinical Psychology, Science and Practice, and was funded through the Robert Wood Johnson Foundation, a larger grant that I kind of became a part of a little bit later on in the process to work with this review. So the first question that I know I had when thinking about this review, and that maybe you also have, is why diagnosable mental disorders as classified by the DSM? I'll admit, full disclosure, as Dr. Gon mentioned, I'm trained as a counseling psychologist. We're not known for our love of psychopathology and embracing of it. So I certainly had questions about, what does it mean to be doing this review, and what's the purpose of it? What's the point? And much to my chagrin, the DSM matters, right? We know it matters, and it matters in a lot of different ways. So first, it serves as our common language culturally, particularly in the US, and our shorthand. So even if we're looking for music on Spotify, let's say, to focus, the first results that come up, ADHD. So when we think about an idea like focus, that's just a human experience, difficulty focusing, and there could be lots of things going on, but it's immediately tied to a mental disorder when folks might be searching for music or sounds to be able to focus. So it really matters that these are really enter the zeitgeist in a way that now kind of describe in shorthand our human experiences. They're also the metric by which the mental health profession measures and conceptualizes illness. And that informs treatment. So health insurance depends on the DSM to decide who gets access to treatment, what type of treatment they receive, and to monitor treatment progress. And that matters for folks who may have concerns that don't fit within those boxes. It creates treatment difficulties. DSM disorder remittance is often the health outcome that's also used by clinical research trials Again, this is sort of intuitive, but just explicitly noting that when we think about what works, what's indicated, what we should be focusing on in terms of treatment, we're using symptom reduction, usually to the point of remittance, where people no longer meet criteria for DSM diagnosis as the outcome to indicate a successful trial. So that matters for how research is structured and funded and valued. I'll also note, I meant to say this at the beginning, but some of the slides, I'm concerned sitting in the back that you might not be able to see them. So I just wanted to give permission if folks want to come down as the slides go on. Please don't feel weird about doing so. You know, they're riveting. So if you need to get closer, I understand. So some of there are prior studies that have looked at specific mental health disorders in the literature. So there's a handful of prior reviews that focus on mental health diagnoses among Native peoples. They tend to either focus on a specific set of mental health disorders, prevalence rate comparisons. So looking how do prevalence rates among Native folks compared to other racial or ethnic groups. Usually it's in that framework. Risk or protective factors, or development and remission of disorders. But to our knowledge, there were no reviews that characterized the broad state of literature among Native communities with respect to these mental disorders. So our research question was, what have we learned from existing research concerning diagnosable mental disorders among Natives in the US? And you might be able to tell even by that research question, it's really broad, right? And so as Dr. Crouch mentioned, this was really fitting for a scoping review, because rather than focusing on prevalence rates or remittance or symptom classification, we're focusing on how the research is being conducted. What can we learn that characterizes the research itself versus synthesizing or evaluating the outcomes of the study itself, if that makes sense. So I'll briefly review methods, and luckily Maria already covered a lot of what applies. So we also use the PRISMA guidelines. And you can see here the flow diagram of searching and screening process. There was a double masked process throughout this screening. So two separate reviewers who weren't aware of each other's judgments or what they decided, whether it fit criteria or not, to ensure some fidelity to that process. The search was conducted in February of 2024. If there's anything missing, that's why it's a little bit ago, from 4 different databases. And I'll just go through briefly the exclusion criteria. So not published in a peer-reviewed journal, if it didn't contain original data collection or novel analysis. So certainly secondary analysis was totally fine, but needed to be novel analysis. Focused on samples outside of the US. They had to include over 5 Native folks in the sample. We were interested, less so in interventions, programs, services, or caregiving. And that was really based on, again, going back to that research question, thinking about how were disorders being described or characterized versus thinking about treatment itself. And if they did not focus on a DSM diagnosable disorder, seems important. And then in the full text review process, there was an additional inclusion criteria that we added after sort of looking through the corpus that we had, that required folks to include at least one multiple sentence standalone paragraph dedicated to Native experience of the disorder. And again, very similar to the rationale Maria used, we were looking for substantive thoughts about Native folks' experiences. And it was particular to the results or findings sections of the article, because as I'm sure many of you know, even in comparative samples, they might have, let's say, one line of a table that refers to Native folks, but then they will go off in the discussion section about interpreting something that they actually gave very little weight to in their design, their methods, their results. So we really weren't looking for pontification. We were looking for this in the results section, how they were thinking about their findings. So what did we find? So we found 152 studies spanning from 1973 to 2024. So you can imagine the range of methods and even conceptualizations that folks were using was pretty vast. The sample did trend female, so 57% of the sample overall was female, 57% adult, 23% child or emerging adult, so anyone under the age of 25, 10% focused on folks over the lifespan, and then 10% on elders. 55 plus, which I know is a little bit of a low threshold for elders. I was nervous about putting that on the slide. And over half were conducted in a rural setting and 16% in urban setting. And the remainder were both. So these were typically national studies, maybe IHS studies that were kind of inclusive of all different categories. And in terms of study setting, we found that 60% were in the community kind of writ large versus in a specific setting or context. The next closest, probably unsurprisingly, is a health clinic or hospital looking at medical records. Then a small proportion actually at a treatment center or a school. And the majority were quantitative, which I think at first, it seems obvious, but I think it's interesting, right? That only 10 were qualitative studies. So there's not a lot of literature that we have that describes the experience of Native folks with a mental health disorder that is qualitative in nature, only 10 over that entire span. So the majority were focusing with quantitative methods. And the majority were also within a Native sample, meaning that they were not comparative analyses. This is a huge number, 81%. The reason that we think that that happened is because of the inclusion criteria, right? So the reality is oftentimes if it's a comparative analysis or if they're included as a part of a larger sample, there's not really substantive interpretations of those results that you see as frequently. So part of our results, we mapped the data onto the IHS regions in the US to sort of see where broadly research was being conducted. Of course, recognizing this isn't a perfect representation, as someone within the Nashville area, I certainly have my thoughts, but we can at least get a sense of what areas are most represented. So we can see the Great Plains is the most represented with 49, and then California with 44. And as we'll talk about, a lot of those 44 are actually generated from a single source. So just want to make that caveat when interpreting this. And then 12 studies were national. And so those are counted in this as representing all of the regions. We also looked when we did data charting at the diagnostic assessment, of course, given the research question, what was the strategy used for how they were assessing whether a participant in the study had met criteria for a diagnosis. We found that the predominant way that this was evaluated is through a symptom screener. So as I'm sure folks here know, a symptom screener would be the GAD-7, the PCL-5. These are short. They were developed for practice with the idea that they would help kind of route people to stepped care for further evaluation or indicative that they might require further evaluation. And then the second most common was diagnostic interview. So those are your SCIDs, the more kind of systematic evaluation of whether folks meet criteria. When folks did use diagnostic interviews, those 58 studies, the most common one used was the semi-structured assessment for genetics of alcoholism with 25 studies. Again, the majority of those are from a single source. And the remainder were just used a handful of times, so not really any others that were kind of dominating. We were also interested, of course, given the time span of this scoping review, what diagnostic criteria or reference folks were using when making this judgment call about whether people met criteria. And we found that the most frequent was a screener cutoff score. So that means that the most frequent way that the criteria that they're using is based on a cutoff score determined by a screener, meaning let's say you get a score of 10 that you are likely to receive a diagnosis of majority depressive disorder. And that's the only criteria that they indicated. This was based on what the authors wrote. So if they didn't connect it to the DSM-5 or wherever that cutoff came from, that's how they received this designation. Because there's no way that other folks reading it would know, where that cutoff score came from necessarily. And the rest, the DSM-3, DSM-4 were the other most common, followed by the others there. And 24 did not note the diagnostic reference or criteria used. So we don't have a way of knowing how they were evaluating whether someone met criteria for disorder. Another way that we sought to kind of represent the results and the span of this corpus was article year by the diagnostic class. So thinking about the DSM-5, the sort of large classes that are indicated, trauma, substance use, et cetera. We wanted to see how things were being studied over time, what diagnoses were maybe more popular to look at a given era. And of course, this is a little bit limited. The diagnostic classes are from the present. We were looking at things from the past. That's something to consider. But the classes have not, some of them have not largely changed over time. And the most common was substance use disorders with 76 studies. And second most common, depressive disorders, perhaps unsurprisingly, was 75. And the next closest and a distant third was anxiety disorders with about 26 studies. So these were really the dominant diagnoses that folks were looking at. And you can also see trauma there, again, given the way that trauma has emerged in our zeitgeist and understanding of disorders. You can see it really began to emerge in the 2000s and become a little bit more frequently studied, but really, really, really understudied if you think about, the language when we all talk about concerns for Native communities, trauma is so prevalent, and we're not really seeing that reflected in this literature. Another way that we charted the data and were interested in seeing themes across the studies was by major project and investigator groups. So what kind of themes in terms of what partnerships were being conducted? Were these all, under a particular umbrella of a study? And what we found is the most common in terms of a project was 8 studies from the Strong Heart Study. So that's a study looking at mortality, morbidity, and risk factors for cardiovascular disease, community engaged, longitudinal epidemiological cohort study in 3 geographic regions, and uses symptom screener cutoff scores to assess for depression and looking at health-related risk factors. The most common investigator groups in the corpus were 16 studies from Ehlers and Gilder, different kind of collaborators with those folks, but that's the classification we used. And the majority of those were focused on neurobiological, genetic, or other risk factors for substance use disorders, with a community sample of reservation-dwelling Southwest California Indians. And the majority of those used, as you'll remember, the 25 semi-structured assessment for the genetics of alcoholism diagnostic interview, which they developed. Okay, so what do we make of all these patterns that we're seeing in these results? The first thing that we wanted to talk about is the focus on substance use disorders. It's the most studied diagnostic class in the corpus. Why might that be? Of course, one explanation is just that, as Dr. Crouch mentioned, we know this is an issue for Native communities of import. Perhaps it's no surprise. But again, we were a little struck by the contrast between the number of studies we found on substance use disorders versus trauma, given that we would have expected those to kind of be a little bit more in parallel if it was truly based on these are Native communities' concerns, if that was what was motivating this. So the other possibility is that it may reflect a wider sociocultural faults, just in case anyone needs to hear that, beliefs and inherent predisposition to alcohol or substance use disorders among Native peoples. And we found that quite a few studies in the Ehlers and Gilder investigator group used racial essentialism as their rationale for the analytic process that they went through. So what is the reason for the study, and its import was based in racial essentialism, meaning race as a biological variable of import to study. So in 2012, a quote that exemplifies that is that ethnic differences in the genetics of alcohol metabolism could potentially modify risk for alcohol dependence across individuals of different ethnic backgrounds. The important part of this is that this is not looking at differences in alcohol metabolism genetically across individuals, which is a great question, interesting question. You can see they're positioning it as ethnic differences. So the way that they're looking at this is necessarily constrained to looking across ethnic groups as the explanatory factor. And we know that this is hardly a new topic of scientific inquiry. It has I think it began more in the 1960s and 70s in psychiatry and has really continued on to this day. It stems from colonial narratives, right, in terms of how alcohol was positioned in service of settler colonialism, both as a device in and of itself and also as a sort of rhetorical tool to talk about Native folks in a way that was racist and disempowering. And the justification for that has changed over time. So of course, in the 1970s, you might find a little more overt paternalism about the benefits of protecting Native folks from themselves in terms of, their weaknesses around alcohol. Of course, that doesn't fly as easily today. So the justified use of goal of this research today is typically around reducing stigma for mental health disorders by positioning them as biological. So the idea is that if it's biological, folks will not feel as stigmatized by suffering from a substance use disorder. And the other stated goal that we found was discovering biomarkers that could eventually prove useful for early identification or prevention needs. So the idea that folks would, through precision medicine that is publicly or population-based accessible, one day be able to be screened early for this predisposition that would route folks to prevention or care. So it's worth asking ourselves, are these goals legitimate and worthwhile? Is this a good reason to be looking at this and for this to be such a theme that we're seeing in the literature? We know that biological framing of disorders, unfortunately, does not seem to help in reducing stigma. So it's actually been found to increase public stigma and hasn't been found to have the impacts that folks were hoping it would have in terms of framing the disorders as biological. We also know that a belief in the biological vulnerability to alcohol is harmful to Native people. We also know it's not uncommon for Native people to hold this belief and have internalized this understanding of themselves, and that understanding is harmful to them. And perhaps most importantly, in some ways, we know that this is a discourse that, again, has continued and seems to be persisting, and that matters for what grants are available, what we see as fundable, what's seen as important and cutting edge. And so when our resources are directed here, it's directing resources and attention away from the things that we know matter. So the more known, potent explanatory factors that we know matter for substance use disorders and risk for substance use disorders, maybe we're shifting attention away from those by focusing on the hoped for future in which folks have access to care, and then that care would be based in genetic screening. Okay, so the next point that we wanted to make about the findings we saw in the corpus were the approaches to diagnostic assessment that were used. So as I mentioned, nearly 40% of the studies use symptom screeners to determine the presence of a disorder. Here's an example, the PHQ-9 for depression, of course, super common given how common depression was studied. And we know that symptom screeners were developed, as I said, to identify possible cases for early intervention or referral. So they were not originally intended to be the diagnostic assessment itself. But the use has extended over time and really proliferated in research. And there's some concerns about what the implications are of kind of using this tool that was developed in one space for one purpose for a completely different kind of purpose with different implications. And one meta-analysis recently found that screeners overestimate the prevalence rates of depression. This was a meta-analysis, I think, with 69 studies on depression, not specific to Native folks, just generally, at 31% compared to diagnostic interviews at 17%. So I'm not going to launch into an entire, conversation about the discourse of mental health disorder in the U.S. right now, but we know that there is a narrative around the illness that is prevalent in our country and that so many folks are suffering from. 40% of people meet criteria for depression, things like that. And we know that a lot of how we're evaluating that is symptom screeners. It seems like we know that that's not actually a super accurate way to think about it. So this misinforms our understanding of disorder development, treatment. What should we be prioritizing? How do we put our resources to good use? It kind of limits our ability to discriminate between different levels of importance. And we therefore recommend more rigorous methods of diagnostic assessment. At minimum, if we're using symptom screeners, which I have in my research, we encourage folks to use the language of depressive symptoms, not disorder. So if you used depressive symptoms, you would not have been included in this corpus because we did not consider that as positioning folks as having depressive disorder. And there were quite a few people who did position it that way. And so just not using them to imply the presence of a disorder. We also wanted to reflect on the use of the DSM writ large, as kind of circling back to that original motivation for this review. So the value of the DSM purportedly lies in the common language it provides and understanding, but whose common language and understanding? So it's based, as we know, in Euro-American patients, physicians and their experiences. And it's not culturally validated. What's more is we seem to have largely moved on from the question of cultural validation without any real reason to have moved on from that. We have no more indication that some of these disorders are culturally valid than we did, 30 to 40 years ago. And importantly, it devalues and dismantles local understandings of distress, illness, and the good life. So it kind of creates a single view or lens for understanding experience that then we all get affected by. So if you think about that internalization of how we're viewing ourselves, even biological vulnerability, that's a reflection of the story that is being told. So for instance, historical trauma or the soul wound, that's not included in this corpus. Unsurprisingly, it's not included in the DSM at all, even as a cultural consideration. So a lot of the things that are most important for our communities or may be considered more important would not be included in this framework. And so it also indicates, by indicating the source of the problem, it also indicates the source of the solution, right? So by having the source of the problem be individual and internal, the solutions are therefore individual. So we recommend that when using the DSM, and as we mentioned at the beginning, there's certainly reasons to use the DSM. It matters. It's how a lot of the language gets positioned, and so it's difficult to live completely outside of that. But we recommend that we strive for cultural validation efforts first and try to pull back to actually understanding what is valid for our communities. Avoid the use of symptom screeners for diagnosis when possible, or at least position them not as diagnosis, so they're not contributing to the overpathologization of Native folks, which I think is a concern that I certainly learned from this review that I want to carry forward with me. And juxtapose disorders with other frameworks, other understandings. So how can we think about experiences beyond the pathological lens to capture well-being and distress? That's it. Thank you.
That's fabulous. Thank you, Dr. Fetter. So appreciate that. And finally, we will welcome Andrea Wiglesworth, who is a member of the Seneca Cayuga Nation and Shawnee tribe. She's a doctoral candidate in clinical psychology at the University of Minnesota Twin Cities, working with Dr. Bonnie Climes-Dugan to study adolescent suicidal thoughts and behaviors. This year, she'll be getting her pre-doctoral internship at the Laureate Institute for Brain Research, where she will work with Dr. Evan White on his study of the neuroscience of cultural resilience in partnership with the Shawnee tribe. Please, Andrea.
Hi, I'm so happy to be here with you all today. I am going to be talking about a literature review that was focused on risk factors for suicidal behaviors among Native peoples. I actually co-led this review with Anna, who we just heard from. And it was a really important collaborative effort, both between Anna and I, but also among our other co-authors, most of whom were psychology doctoral students at the time of this work. So you can see Little Dove Ray, Michael, Micah Prairie Chicken, who some of you may know, same with Michael, Amanda Young, Amy Reigelman was our librarian, who I'll talk a little bit about and sing her praises, and then Dr. Gon. So suicide behaviors, as many of you may know, we know that Native folks are disproportionately affected by suicide in many of our communities, though not all. Across the lifespan, particularly from ages 10 to 45, Native people are more likely than folks from other racial or ethnic backgrounds to die by suicide. And even when we look within Native peoples, this early life period is our highest risk period. So thinking about early adulthood. And unfortunately, rates of suicide among Native peoples have increased or remained stable over the past few decades. So from 2015 to 2020, we saw a 45% increase in suicide, and these numbers are projected to continue to increase into 2030. In thinking about how we might intervene here and have effective suicide prevention efforts, I think about the importance of studying suicide behaviors. Thoughts about suicide are obviously really important and signal some distress and some level of risk, but something we know from the general literature is that most people who think about suicide do not go on to act on those thoughts. And something that our research doesn't really tell us is how do we differentiate the people who are at risk for these behaviors from those who are still experiencing this distress, but will not go on to actually be in danger of ending their life. And we know that suicide attempts are really dangerous behaviors. Of those who die by suicide, 70% die from their first known attempt. So the opportunity to intervene after a suicide behavior is really limited. So it's really critical that we begin to understand the risk mechanisms for behaviors so that we can intervene in a timely manner for these folks. In preparing for this literature review, we wanted to know, what is out there? What have folks already done in synthesizing the literature? So we looked pretty specifically to find reviews focused on Native folks and suicide, because again, as I just mentioned, obviously risk for suicide is related to mental health and well-being. And when we're thinking about intervening on these particular behaviors, we wanted to look to see if that was already done, if someone had already synthesized that body of knowledge. We found 3 related reviews that each spoke to unique pieces of suicide thoughts and behaviors among Native communities and had really important things to say, some of which you'll see actually in our discussion as well. The importance of focusing on risk and resilience pathways, not over pathologizing individuals, a lot of themes that actually were carried in the previous presentations. So we came to this review question. What do we want to know? What do we know comprehensively about statistically analyzed risk factors for suicide attempts among Native populations? So in answering this question, we had to go about selecting a review methodology. Now we've all heard about how important this is, so I don't need to go over it. But because we wanted to know comprehensively, what do we know about risk for suicide behaviors, we undertook a systematic review so that we could robustly characterize the state of the knowledge on risk factors for suicide attempts, really with the goal of informing theory and future directions. Even in knowing we're doing a systematic review, we still have to make a lot of decisions as far as the scope of the review, because the scope really defines what we can say and what we can speak to. So our scope we defined through kind of 3 main areas. One was the population, so focusing on Native peoples. The second was the data type, what is going to be included, what will count. Here we decided to focus on quantitative data, really as a practical decision to limit difficulties in synthesis based on heterogeneous methods, research methods, and having a manageable corpus size. And then study types. Because we wanted to, again, robustly characterize state of knowledge, we included published and non-published literature. We really wanted to get like any piece of knowledge at all. So we tried to be really comprehensive here. Then we went through the steps of a review process. So we have kind of heard more about this already, but we undertook a search of 12 databases led by Amy Reigelman, our research librarian, who was really, really helpful in this review. This returned over, I think, 3,000 articles originally that were deduplicated to about 1,700. At that point, we undertook a screening process. Here, as was similarly described in the other reviews, we had double screening. So each article was screened by 2 individuals for inclusion and exclusion criteria. For this study, our inclusion and exclusion criteria, again, kind of define the scope. So the first inclusion criteria was that there must be an appropriate sample of Native peoples in the study. And we defined that as having at least 90% of their total study sample being Native. And so what that means is we don't really have between group studies here. It's mostly a within group, like specifically focused on Native peoples. We also wanted an inclusion criteria that they must statistically examine a relationship between a variable that might act as a risk factor for suicide behaviors. And this is based on the authors positioning this as a risk factor, not based on us saying it's a risk factor. And a non-fatal suicide attempt variable. This inclusion criteria actually was maybe the trickiest to get down, but we really wanted to know, like in this quantitative literature, what is the evidence for these different risk factors and how strong is it? So then we had some exclusion criteria that really reiterate a lot of what I've already mentioned. If they were not original research, so reviews or law briefs, they would be excluded if there were no statistical analyses. So this kind of captured qualitative analysis or case studies. And then also if they focused on other self-injurious thoughts or behaviors or combined those with suicide attempt, because that's actually quite common, is to have like a suicide risk variable that's very broad. Whereas we wanted to find things that are more specific to suicide attempts. I won't go through our whole Prisma diagram, but we had 3 screening phases. The initial screening phase was just title and abstracts. The second phase was a full text, so the entire article for 670 articles. And then phase 3 was kind of refining, a refining phase. And our reliability for the first and third phases were strong, and our reliability for second phase was moderate. And a lot of that was really due to ambiguity in whether authors were positioning something as a risk factor. That actually is where most of the disagreements lied. After screening, then we extract. So we pulled out all of the important information so that we could synthesize. So this is where we really gathered everything that we would need to learn something about the data. So we looked at sample descriptives, the analytic approaches that authors were taking, the results, and the author's interpretations, which ended up being really helpful because, spoiler alert, a lot of times there were none. And I'll talk a little bit more about that in a little bit. To organize our review, we wanted to identify a framework that would help us to really get a sense of or grapple on what we were seeing. So we used the ecosystemic framework by Burnett and Figley, which they proposed in a review on Indigenous mental health. And this is really designed to think about how individuals exist within context, and specifically for Indigenous folks, how culture and history are important pieces of that context that are often left out in like a Braun from Brenner ecological systems model. So let's go through the results. I will say at the top, in a lot of these categories, we were able to identify like umbrella constructs. So generally, what are people interested in? But when it comes to the specific risk factors, they were so different across studies. It was really uncommon for the same construct, the same measure, the same question to be asked across studies, making it really difficult to synthesize. So there will be some moments where I say, this general idea was studied across 3 studies, but in slightly different ways. And for time, I will try and breeze past some of those because I think the discussion really is the most interesting part here. So we had 45 articles in our final corpus. 36 were published peer review articles and 9 were unpublished theses or dissertations, which is a pretty substantial portion. If we look over at the corpus in whole, 55% of the studies were focused specifically on American Indian peoples or communities, 38 on American Indian or Alaska Native, and only 7% were specifically focused on Alaska Native folks. Child and emerging adulthood was kind of the most studied age range, so 67% of studies. About half of the studies were original data collection, and similarly, about half were secondary analysis. Secondary analysis here was usually these large-scale screening health risk surveys, like by the CDC, for example. And then for settings, 53% were in schools. Again, a lot of those were those broad health risk screening surveys, with about 9% of studies from clinics, 7% from treatment centers or prisons. So very, and then the rest would have been just not at all described, like general community. There were a lot of risk factors studied in this corpus. So per study, the average number of risk factors examined was 6.5, and this ranged from 1 to 31 across the studies. So imagine setting up a theoretical argument for 31 risk factors. That's not what we saw. When we look at individual level factors, this is not going to surprise anyone in the room. These were the most studied. Most of the corpus was focused on individual level factors. Demographic and regional characteristics were of interest. The most robust here was seeing patterns of female youth being more likely than male youth to have reported a lifetime suicide attempt. We saw some effects related to age, but that actually wasn't even that frequently studied. It was looked at in 3 studies. And 4 studies looked at broad regional differences, reservation versus urban, And for the most part, those were not significant, which again, when we're thinking about who that includes and how broad that is, I'm not that surprised. Personality and psychopathology was the most studied section. Depression and hopelessness really was the one area where we saw robustness in results. So across these 12 studies, if you reported a suicide attempt, you were more likely to have reported depression or hopelessness. I don't know that any of us are surprised about that, but it was nice to see that it was actually robust. Suicide ideation was very rarely examined actually as a risk factor for suicide attempt, which I found surprising. And then I'm not going to go through them, but a number of other mental health diagnoses or symptoms were examined as well. As we are, again, probably not surprised, substance use was also examined quite frequently, and for the most part was pretty robustly related with suicide attempts. This was much more frequently studied, though, among youth than among adults. And risky behaviors, this is one of those that there were not multiple studies studying the same thing, but there were, a laundry list of risky behaviors that were looked at in relation to suicide attempts. I have more thoughts on that later. And then lastly, here, health utilization and characteristics. So again, a variety of different constructs related to health care utilization or physical health characteristics. Next would be family related level factors. And the main point that I want to make here is that family level factors were almost entirely examined among youth. So only a handful of studies looked at anything related to family dynamics among adult populations, which to me really stood out. And I think a lot about like, how do we see adults as existing within families? And this literature would suggest that we don't, which is pretty problematic. But when we do look at the research, we see that family structure and characteristics were studied. Family structure really did not come out as related to suicide attempts, but some family characteristics like loss of a family member, family conflict did. Family history of psychopathology was also examined, and in general, there were small effects. And then child maltreatment or abuse were examined as well. And so you can see those are our two adult studies there. We're focused on child maltreatment, not even their current relationship with family. Community level factors, similarly, were actually only studied among adolescent samples, and most of these were focused on school. So again, the way that adults are being characterized in this literature is not taking into account context, it's not taking into account their relationships and the spaces that they exist within. So when we look at community level factors for adolescents, a lot of studies focused on violent victimization and interpersonal conflict and bullying. And in general, these stress experiences were found to be associated with risk for suicide attempts. Similarly, friendship factors like having a friend who attempted or died by suicide or feeling limited social support were related. And again, a lot of these were focused on school, so some school factors as well. Cultural level and historical level factors were really rarely examined. So 3 studies looked at cultural level factors and did not find any significant associations between cultural traditionality, religiosity, and engagement in cultural activities with suicide attempts. And for historical level factors, there were some studies that looked at racial misclassification, which is a racial stressor, boarding school attendance, discrimination, and a couple studies that looked at historical loss symptoms, which did not find links to suicide attempts specifically. Okay, I'm pressing the wrong button. So what does all this mean? Let's try and use 2 minutes to put some thought to this. So using, kind of looking through this literature and then also thinking about the broader suicide literature, we tried to bring our heads together to think about what do we really need to move this body of work forward to really aid suicide prevention efforts. And we landed on kind of 4 areas. The first is theory-informed research. So something we noticed across the corpus was a real lack of theory-based model building and theory-based model testing. This meant that there was a lot of heterogeneity in research design that was also really unclear. We weren't sure why people were taking certain approaches. it was really rare for studies to really delineate mechanisms of risk, which also meant that when results were not significant, they often went undiscussed. So we didn't know what that meant or what future researchers should even do about that. Is that something we need to follow up on? An example here would be risky behaviors, carrying a weapon. So carrying a weapon was considered a risk factor for suicide attempt. But we can think of a lot of ways in which this could be a risk factor, right? Is it that this weapon could be used for self-directed harm? Is it that this is a proxy of externalizing behaviors? In either case, those intervention approaches might be different. So understanding those mechanisms is actually really important for informing our interventions. The next is clinically informative designs. So the entire corpus was cross-sectional. And so what we weren't able to do is understand the temporal associations between these factors. So a really clear example that comes to mind for me is substance use. There's some research that comes out of the Johns Hopkins and White Mountain Apache collaboration that highlights how for a lot of youth who make suicide attempts, they were using substances at the time. And what we don't know is the temporal nature of how that happens and in what context. So research that can outline the weekly, daily, and momentary relations between these factors can really highlight for us how risk is unfolding, and again, moments where we could intervene. The third point is needing an intersectional and cross-cutting framework. So we really found an overabundance of individual pathologizing in this literature. We did not see a lot of contextualizing Native peoples in their lived experiences in ways that really matter. So because of that, we might be missing out on a lot of opportunities for prevention that really engage families, community members, systems that place people at higher risk rather than focusing on the individual. One just short way of highlighting that in the demographic characteristics, you'll notice there were not studies that focused on gender identity, sexual orientation, other racial or cultural identities. Just the general contextualizing was really limited and something that we need in future work. And then finally, this is related, but really needing to focus on culturally relevant and societal factors. So moving beyond the individual level and expanding our work on societal factors. We know in the conversations we have that historical loss, historical trauma, discrimination experiences, these kinds of stressors are likely really important for suicide risk, for mental health, and for well-being. What we don't know is how those come up for people in their day-to-day lives to influence if and when they're going to engage in a suicide behavior. That's something that we really do need to know and a place for us to expand. So I am over my time, but I'll just say that the process of doing this review really for me was the most important thing. I was able to make friends and colleagues and mentors that have helped shape my growth and development as an Indigenous scholar and psychologist. I was the earliest career person, which was great. Find yourself older friends. It's fabulous. Because I've really been able to just watch what they do and like follow in their beautifully laid footsteps. I feel very blessed for that. It also has been really formative for me in shaping my future program of research. So a lot of the work that I'm actively doing now has come out of these reviews and identifying gaps and trying to do just the littlest bit of filling those gaps. So I really encourage students, early career folks to engage in a review such as this to really set yourself up for the kind of work that you want to do as you engage in the field and bless us all with your knowledge. So cool, thanks.
All right, well, I think we've been adequately stimulated by a lot of ideas and a lot of information, and now is a chance for us to collectively process some of that. So I think is there someone who can run the microphone, please? The microphone, I think, is on the stand. I want that to go around to anyone who might have a comment or a question. We've realized recently that collectively we're an indecisive bunch. So maybe just to keep things moving in the next 10 or 12 or 15 minutes we have, I'll call on folks. But please, if you can, address your question to who you'd like to respond, if that makes some sense. So Dr. Boyd.
One thought and then one maybe more question. I think you see the predominance of substance abuse and to try to dismiss substance abuse as a problem in our communities would be inaccurate. But at the same time, there's that concern of we want to blame everything on substance abuse and not look at the causes of substance abuse. It could be masking other things. And I'm reminded of it's quite a while back, a study that was done. I think I published it in JAMA, where they had the same presenting symptoms and they varied the race and gender of the presenter, male, female, Caucasian, African American, and saw very different initial diagnostic rule outs by physicians. I kind of wonder if you see the same thing with Native people, if there's just an assumption that they're either high or drunk, even when they may be presenting with other, and if that would bear out in a similar kind of maybe experimental design based on what we're seeing here. But the other thing was more this notion that we have a biological vulnerability, and trying to contend with that with sort of the findings in epigenetics that we kind of do, but that maybe even if that's more of an individual thing, that, you know, epigenetics is telling us much more about our health, including our mental health and things like that, and how we can address that going forward and kind of learn from that knowledge without just reducing it back to a stereotype of well, you know, Indians are just vulnerable to alcoholism and suicide and all, and just because they're native, and not looking at the actual science of that, because it becomes a real easy way to just, again, blame it all back on biological factors.
You have a mic there. Does that work? Please.
Yeah, it does work. You want to take it first?
Yeah, I'll go with the first one just because I think it's related to some of the thoughts that I have around substance use and suicide. I completely agree that thinking about why folks are using substances is really important. For the study that I referenced from Johns Hopkins and White Mountain Apache, these are use only reports of their behavior. So I think for that, we can have a little bit more clarity versus when we're thinking about autopsy studies, which happen a lot, right? And we know probably are miscategorizing who is native anyway, and whether substance use is actually part of the bias in that. But for this youth study, that's kind of why I think we need to actually look at these clinically, what I call clinically meaningful timescales, because looking at, have you ever used these substances or to X degree, and have you made a suicide attempt, doesn't tell us much. But if we can look at like what is actually happening in those weeks and days and moments before we're using substances and making a suicide attempt, we can really disentangle that. So is it that folks are having a stressful experience and now this is a coping mechanism, right? And in that coping mechanism, there's this increased vulnerability. That's what I would assume. And our literature does not tell us that. So we really need to highlight those, the sequencing of how these things are happening. That's only one. Was that off the whole time? No. Okay, thank God. Well, I'll pass it along for the second half.
Just in regard to the epigenetics, I'm not a geneticist, clearly, hopefully clearly. But if anyone is interested in epigenetics and wants to talk to me, I would love to hear your thoughts. I've tried to befriend geneticists to try to learn. But something that I think I have learned is around the way the question is framed and then what it could possibly tell us about epigenetics. So much of it is oriented around these racist biology frameworks that then lead to how race is categorized as genetic, and then the samples are sorted in a predefined way that really is difficult to understand or find much meaning in. And then those differences are found across genome scans that are enormous. And then you're looking at a small bivariate correlation between, let's say, white and native participants. And you've looked across so many different areas of the genome and found one, and it's, let's say, 0.2. And then you don't find it next time. And that, my understanding, again, if people know more, I would love to hear, but is that that's often the case, and then those are not replicated. And so my wonder is like, is this the most helpful line of questioning to go down when we already do have evidence that epigenetics is not as informative as other things, like having someone to talk to. There's a huge study by the VA looking at predictors for PTSD with the hope, I think, sort of with the hope of finding epigenetic risk, and the largest risk factor or protective factor was having someone to talk to about your trauma, just anyone. So I think we can hold epigenetics and also remind ourselves that the way it's being studied is to tell a specific story, and that story is race-based, versus looking at communities who experience certain types of trauma perpetuated by the systems of oppression that we live in.
Yeah, thank you for that. I just wanted to add, the answer being that no, genetics doesn't play a factor. It does, but it's so incredibly small. Like, so when I think about, my interest is more so in terms of like genetics and trauma, just in seeing like how things are expressed and passed down, because that is permanent and that makes sense. And in terms of the effects that it causes for folks. But when we think about substance use disorders, one, we know that the genetic implications cut across all race and ethnicity. They're not specific to one. There was one study done a long time ago. It was previously called the firewater myth. Now we know that is, well, now others know that's racist, so they call it, biological vulnerability, the myth of biological vulnerability. But nevertheless, that original study persists and it was discredited for one. And all, and the conversation is around like, yes, this cuts across all peoples, but it makes up such a fractional percent of risk and who develops a substance use disorder. What makes up the larger percent is it in your environment? Do you have access? That's what makes up the largest percentage. And then also, are you experiencing trauma, emotion regulation? Do you have people in your environment to help you? Because guess what? Drugs and alcohol work, they just don't work for a long time. And so anyone is susceptible to substance use disorder. And in terms of the substance use disorder, literature, we know that Native people are using substances less than other racial groups, other, ethnicities, but we experience more substance use disorders. And there's a lot to be said about that. There's perhaps pathologizing. We have internalized oppression. We do know that we have more rates of binge drinking, for example. So that's really risky behavior that leads to a lot of other things. So there are a lot of things going on. Trauma is really an integral piece that we need to look at. But one thing I will say about that is it's really hard to do trauma research among Native communities. I have an APA study now. I wanted to look at historical laws. I wanted to look at all these pieces of trauma. I want to look at cultural identity. I want to look at form of life. And the community said, no, I don't want you to look at that. You can just assess this alcohol piece. And that's understandable and that's fair. So doing the research that we want to do, we also have to step back and understand sometimes it's very difficult. It's not something that you can get through. And so we have to do it sort of piece by piece and step by step. And it takes a really long time in our communities, and there's reason for that.
I was just going to comment that in this discussion about, epigenetics and environment, I think we really need to be careful, and something we can bring to the table is having a holistic view. I hear us falling into is it biology, is it environment? But the whole point of epigenetics is that genetics is not deterministic. It's very much influenced by our environment, and our environment influences that. And so, I'm just sitting here thinking like, gosh, I have to be really careful not to fall into that mainstream model of either or determinism, because that tells us so much about what we can do in our environments does shift those biological vulnerabilities, which we all carry with us, and all are given by our experiences every day, or our biological strengths. It's really empowering, I think, if we remember that holistic perspective, that it's not either or. Just a comment.
Maybe just one last comment or question before we wind down for this morning.
Yeah, it's tangential to this, but I appreciate what you were doing in your presentations. I wanted to let you know that Vivian Ottawang is now Deputy Director of the Office of Women's Health at NIH. And she and I rode back from the National Multicultural Summit together on the plane. So we had some time to talk. And she would really like to have some Native early career psychologists applying for some research. She's willing to work with you in developing a grant application. And I would be happy to connect anyone with her, do an introduction. But there's been money infused into this area through Joe Biden's work. And they've got the money. They would really like to get some Native researchers in there to get it out too. So thank you.
Thanks, Dr. Gray. And thank you all. Let's offer our gratitude one last time to our panelists.